Right now, I'd say emerging therapies, we do know that BRAF inhibitors work for patients who have a BRAF mutation, and that's actually been documented over the last few years. So I wouldn't necessarily say that the BRAF inhibitors are emerging, but they are agents that we would consider after sorafenib and lenvatinib. But because sorafenib and lenvatinib have more data, they're both FDA approved, those tend to be the first and second choice for us. Then we would go to a BRAF inhibitor if they have a BRAF mutation. Similarly, there are emerging therapies for people with TRK translocations or with a RET point mutation or translocation. And as those clinical trials come to their fruition, we might choose some of those activities specifically for those small number of patients that have those mutations. But for all comers, recent data that we've shown through a phase 2 with cabozantinib, we know that that's very active in this tumor type as well. And there is also data shown at Ohio State. So we have 2 phase 2s that are completed that show that cabozantinib also works in differentiated thyroid cancer. Now, many oncologists will be aware that cabozantinib is FDA approved in medullary thyroid cancer. But now we actually have data that says that it's active in the phase 2 setting, and now going forward there is a phase 3 that will be testing it sort of in the second, third line setting. So after either 1 or 2 of the other drugs, you can go to cabozantinib as a second or third drug or beyond. And so that's another emerging therapy. I've seen great activity in my patients who've gotten to it in the second, third, fourth, some even later have had other therapies first, and it's also a very active agent. So that's another exciting agent, I think, coming down the pike.
So immunotherapy is an extremely good question for thyroid cancer. There has only been one really published study with immunotherapy in differentiated thyroid cancer. That was a study with pembrolizumab. It was in PD-1 positive patients or tumors. The response rate was not very impressive, only around 9%, but it wasn't that bad of a median progression-free survival, around 6 months. Not as good as you see with the TKIs, but still something that's doable. It was something that only seemed to be used in follicular and papillary thyroid cancers. The reason why I mention that is that there's been more and more data in Hürthle cell thyroid cancers that the mutation burden in these tumors are higher than you see with papillary, and these might be better targets altogether. We have seen a few patients who actually seem to be good candidates for immunotherapy, and I do have to say that I do treat a few patients off study with immunotherapy and get some activity. There are patients who you just cannot give a VEGF TKI to, either because they had a bad side effect, proteinuria that never goes away, or the high blood pressure that cannot be controlled, and you just can't use it for it, or for patients who we've used every other drug for, and using immunotherapy, I've had a few patients who are able to keep their disease check in a while.
The problem in thyroid cancer is that as in all cancers, that patients can become resistant to treatment. And in many cancers, many molecular pathways are being activated. And if we treat patients with a drug that targets only a few of those pathways, we can expect that the cancer in the end escapes from the inhibiting effects of the drugs by activating other pathways. Also, novel mutations can occur that bypass the effects of the treatments. So I really believe that combination treatments that target multiple pathways are important. Examples of those combinations are treatments that target both the PI3 kinase pathway and the RET-RAS-RAF pathway. But there are other combinations that you can think of, especially combinations of immunotherapy and kinase inhibitor treatment.
Now, I think the more exciting thing that's going to happen with immunotherapy is going to be more with combinations. So using immunotherapy, PD-1 drugs with something else. There is a national study that Brian Haugen from University of Colorado is running, looking at the combination of pembrolizumab and lenvatinib. And there's already been a lot of exciting data in other cancers using lenvatinib and pembrolizumab together. And so using this in thyroid cancer makes a lot of sense. And it is something that I think a lot of us should be excited about to see what those results are. In addition, we have a study looking at using radioactive iodine, a small dose, with Durva, a PD-L1 antibody. And there's a lot of rationale of using a little bit of radiation, almost having like a little bit of an abscopal effect, but also by using the thyrogen, having increased antigen presentation to try to improve responses to immunotherapy. There are going to be many other combinations coming around, and we actually expect that probably within next 6 to 12 months, we'll probably have 4 different immunotherapy studies going on in differentiated thyroid cancers using different combinations. So while I think PD-1 as a single agent does not seem to have a lot of activity, it does work with some patients still, and it is something that can be done when other drugs cannot be used, at least to be considered. But I think with the combinations, that's where I think most excitement exists, and I think we're going to see a lot of studies occur over the next few years to really know if these combinations end up working better.